And moving on to dementias, quite an open field. I could lecture you for 2 days on dementias, so I'm going to try and do it in 5 minutes. So the background of a dementia, so it's a progressive irreversible decline in multiple cognitive fields that is irreversible. And we talk about various domains: memory, language, behaviour, visuospatial, so interacting with your environment, think about things like driving, for example, or executive function, so trying to make decisions or synthesize information and come up with a solution. Multiple domains are generally affected, particularly as the disease moves on. So certain dementias may predominantly affect 1 or 2 domains initially, but they tend to affect multiple domains, all of the dementias with progression. And the rate of progression depends on both the condition and the individual. So the most common dementia, Alzheimer's dementia, can be very rapid in some people and can be very slow and indolent in others. And all forms of dementia are made worse if the patient is unwell with an infection or something like that, and a delirium will always worsen a dementia. Sometimes a dementia becomes uncovered because somebody comes in with a decompensated delirium and it becomes clear that there's an underlying dementia as they recover poorly or incompletely. So Alzheimer's disease is the commonest form of dementia. And the way to think about it is this is an amnestic dementia. So it is a disorder of memory and forgetfulness. It's a tauopathy, so we have abnormal tau deposits in the brain, and pathologically we hear about neuritic plaques and neurofibrillary tangles. Try saying that without your false teeth. That's what we tend to see on pathology. Early memory function is what we'd expect. There can be some sort of neuropsychiatric personality changes, but it tends to progress slowly and it can really creep up on people. We sometimes see a patient who has had slow changes in their memory and personality over many years, and this may have been sort of compensated for and covered up by their spouse, and then if their spouse becomes unwell and goes into hospital, or unfortunately there's a bereavement and the spouse dies, it then becomes clear that this person has been functioning less well for a long period of time, and now that's no longer compensated for. In terms of imaging, we see hippocampal atrophy, and if you do functional imaging like a PET scan or a SPECT scan, you see that the temporal parietal lobes are much cooler because there is less activity there. So there are some genetic conditions that can make you more likely to develop Alzheimer's disease. So trisomy 21 or Down syndrome. People with Down syndrome almost invariably, extremely commonly develop Alzheimer's by the age of 40 or 50. There is an allele, the ApoE alleles, and if you carry 2 4s, you are much more likely to develop Alzheimer's disease, and families with ApoE4 tend to have a very strong family history of Alzheimer's. And presenilin 1 is another genetic condition which can predispose to an Alzheimer's form of dementia. In terms of treatment, after diagnosis, we use acetylcholinesterase inhibitors, and that's to try and boost cognition. And it can improve function in earlier disease, but it doesn't change the eventual outcome. It doesn't change the progression of the disease. And those medications are donepezil, rivastigmine, and galantamine. We use a lot of caution if there is a slowed heart rate or significant cardiac disease, because we know that donepezil and its sisters can cause further slowing of the heart rate and can precipitate heart block. So it's really important to do an ECG before starting any of these medications. And if people have bradycardia that is significant, then they should be avoided. It can also worsen urinary function, give you a lot of urinary frequency. Another medication we use as a cognitive enhancer is an NMDA antagonist, memantine. It doesn't have those same cardiac effects, so we often use that if the acetylcholinesterase inhibitors aren't possible due to cardiac issues. This is some imaging of classical Alzheimer's dementia on just structural imaging. You can see the hippocampal atrophy, so the shrinking of the temporal lobes and the hippocampi there bilaterally. And on SPECT imaging, you can see that the temporal lobes are just kind of cool and blue and purple, as opposed to being hot and yellow-red. Those are usually very active areas in the brain. Frontotemporal dementia is rarer. It occurs in a younger set of people. there's generally a male preponderance, but obviously we do see many women with it, and that affects more behaviour, fluency, executive function and decision making, as you would expect with something that affects the frontal lobe. In the younger onset dementias, a greater proportion of people will have FTD. Parkinson's disease dementia affects the frontal lobes, but that develops some years after motor features of Parkinson's disease, and we don't classify Parkinson's disease dementia as a frontotemporal dementia per se, but it's important to realise that Parkinson's disease dementia does affect the frontal lobes quite predominantly. Clinical features of FTD can vary, depend on the type. The most common is the behavioural variant of frontotemporal dementia, or BVFTD, which sometimes is known as Pick's disease. And these patients have changes in their behaviour which can make them very difficult to live with. People might get fired from their job, they become disinhibited, they might become sexually aggressive, they may start telling people uncomfortable truths, so stopping people in the street and saying, you know, you're really fat, which is generally very out of character. Most of us don't do that, and that's because they lose the ability to sort of socially modify their thoughts. We all have thoughts, but we usually don't act on them, and that's because the frontal lobe allows us to modify our behaviour to be socially acceptable. It's difficult to control your impulses, impulse control problems. So people become very overt with their wants. So they might be, again, as I said, sexually aggressive. They may touch people inappropriately without permission. They may try and kiss someone. So if I'm in clinic and a patient grabs my shirt and tries to kiss me, generally they have a frontal lobe problem, generally. They may, grab somebody's sandwich and start eating it. They develop a taste for sweet foods. They may lose their adult palate and they just want to eat lots of sweets. They put on a lot of weight because they can't control their behaviour and their desires. They become quite childlike in a lot of ways. There's another form of frontotemporal dementia, progressive non-fluent aphasia, which is becoming known, unfortunately, as Bruce Willis disease, which is the condition that Bruce Willis likely has. So people become less fluent, their speech becomes very effortful. Folks will describe, it's trying to force out words through treacle. I just can't get it out. And then eventually they completely lose their speech. As the speech is lost, they may develop more personality change and disinhibition, like we would see in behavioural variant frontotemporal dementia. And I think the way to kind of think about progressive non-fluent aphasia is that the speech contains appropriate content. People know what they want to say, they can try and get it across, but it's just very effortful. It sounds like I need to explain, and when people eventually get it out, it makes sense, but it's incredibly painful to watch people try to communicate. They're so frustrated. And when you look at imaging, they often have atrophy of the left temporal lobe, which is quite asymmetric. There's another form of dementia, which is very rare, called semantic dementia, which falls into the FTDs. And people lose the meaning of words, of concepts. So, and their vocabulary becomes narrowed, and they get more and more simplified speech. So, for example, if they were they will lose the concept of rare things first. So they would lose the concept of a zebra or a rolling pin or I'm trying to think of a rare thing, a medieval trebuchet, first of all, because you don't use those concepts very frequently. And if they were trying to describe a horse, for example, as their disease progresses, they would say, it's a big dog that you ride on. Their speech becomes very simplified and they try and then explain concepts with a limited vocabulary, but also lose the concept of what those things are altogether eventually. And we see bilateral temporal lobe atrophy there. They also have a very rigid way of seeing the world. So you will have someone come into clinic and they'll say, my appointment's at 9 o'clock. I'm sorry, we're running a little bit late, but it's 9:10. I know, but we're just running a bit late. We'll be with you as soon as we can. But my appointment was at 9 and now it's 9:10. They have very rigid routines as well. All of the frontotemporal dementias can, but semantic dementia seems to be quite predominant. And these are some of the FTDs that we would see. So we see left temporal lobe atrophy here in a progressive non-fluent aphasia on the left, and on the right we've got generalised frontal lobe atrophy in somebody with behavioural variant or Pick's disease. very rapidly, just running through some other forms of dementia. Posterior cortical atrophy is a condition that mainly affects visuospatial function, so it's atrophy of the parietal lobes and the occipital lobes. People just become unable to interact with their environment. This is what Terry Pratchett had. So his ability to write and to speak was largely unchanged for a long time, but he had to be led to a chair and had to just sort of feel the chair and couldn't really understand how to make his body interact with the chair and had to be sort of guided to sit down. And I did see Sir Terry not long before he died, and he really struggled to interact with his environment. Lewy body disease, it can be thought of as a variant of Parkinson's disease dementia, but whereby the cognitive or dementia symptoms precede any motor symptoms. So people present just with fluctuation, visual hallucination, altered behaviour. They may not have any physical symptoms suggested of Parkinson's disease or very mild, and they often have a lot of autonomic problems, so lots of urinary frequency and quite disabling drops in blood pressure, and they're very sensitive to medication. In Parkinson's disease dementia, by contrast, people have motor symptoms for often many years before they then develop cognitive symptoms. So Lewy body disease is almost like a photonegative of Parkinson's disease dementia. The cognitive stuff comes first or at the same time. Parkinson's disease dementia, you have to have motor symptoms for at least 12 months before developing cognitive symptoms. Vascular dementia, you might have that after a single very disabling stroke or a number of strokes, and people tend to have lots of small vessel wear and tear. It's more common in people with diabetes, untreated hypertension, and in peripheral vascular disease. We tend to describe that as stepwise decline, and that suggests, infarction of discrete areas making the cognitive function worse. And then there are metabolic forms of dementia, like Korsakoff's, which is alcohol-related after prolonged alcoholism, and it can also be caused by prolonged micronutrient deficiency. Korsakoff's often goes hand in hand with Wernicke's, encephalopathy, which is treatable. You would have eye movement problems and confusion with confabulation. So confabulation is where you just kind of take hints from your environment and you just produce a stream of consciousness. So I can see the very lovely Tom filming in front of me, and he's wearing a rainbow lanyard, and I would say something like, oh, well, actually yesterday, what was I doing? Well, yesterday I was making rainbow lanyards, and I make rainbow lanyards for the whole country, and I'm the biggest rainbow lanyard producer in the whole world. Or you'd see somebody with a little skiing like emblem on their shirt, and you would look at that and you would say, what were you doing this morning, sir? Obviously they've been in hospital lying in bed. Oh, I was skiing this morning. Tell me about your skiing. Oh yes, I was skiing on this mountain and this mountain and this mountain. And they're just taking prompts from their environment and just giving you information. And they do believe it. They're not lying. This is confabulating. So in summary, dementia is progressive, it's incurable, and it involves multiple cognitive abilities over many domains. There are very few disorders that we call dementia that are reversible, but we'll get to that at the end. The presenting features depend on where the dementia originates. So Alzheimer's dementia, temporal lobes, hippocampi, memory, forgetfulness. Frontal lobes, behavioural change, rigidity, impulse control problems. Mimics of dementia should always be looked for and treated. So if we suspect somebody has dementia, they should always have imaging of the brain, particularly if they've got focal signs. Sometimes you find a brain tumour, for example, in the frontal lobes, if you were thinking about FTD. Malnutrition, nutrient deficiencies, severe depression. So severe depression can be thought of as pseudo-dementia, and with treatment people recover. And profound hypothyroidism, rare but possible. And the mainstay of treatment, unfortunately, because we at this time can't cure dementia, is education, support, multidisciplinary input, and sometimes cognitive enhancers can help with symptoms.